He is the head of the clinical unit for emergency medicine at Power Hospital. He oversees the emergency care within the area of Vredendal to Stellenbosch, with a primary focus on the Drakenstein district. He is an honorary lecturer at UCT, Division of FACE, which stands for Family, Community and Emergency Care. He is a lecturer at Stellenbosch University, Division of Emergency Medicine. Okay, Dr. Aziz.
Everybody. I'm going to be chatting about the latest updates in resuscitation. So it's not, I'm not going to, we've got 25 minutes, so I speak fast, so hopefully it will go a bit faster. But we're not going to go over how to do CPR, what the ACRS protocol is, what the basic life support protocol is, but just updates from the 2023 ILCO co-star, and what has been updated in the interim. And I think the most interesting things are in the ACLS updates. And then lastly, just how do we implement that practically in a resource limited setting. I know that in private it's very similar to the states, whereas in the state sector it's a more resource limited setting. And in taking that into the pre-hospital environment, and we're going to focus on the out-of-hospital cardiac arrests. My brother said I shouldn't mention him, and if I do mention him, I've got to say that I'm adopted. But I always think of how do you deliver these lectures, because I see at least one resus a week, and I'm sure the majority of the audience members think, hey, but we see this once a year. So we try and tailor it for the majority of the audience, which is not that regularly, but then bring it back to what we do in the emergency center, and what can we do to practice all of these things. So just an overview of the lecture. We're going to talk about when should we initiate CPR, when should we withhold CPR, and there's quite a few times we actually should withhold CPR. Recap and list some of the 2023 ILCO recommendations, and then just talk about the South African perspective. And then just to summarize the lecture, like if you want to know anything, like a 2-second snippet of it is, if you, while I'm talking, you can watch that. But that seems to be how most of us, well, not most of us, how lots of people tend to respond to CPR. But if we think of how, what the nuts and bolts of CPR is, it's still the basics. It is still first responder. It is the community getting there and doing chest compressions as early as possible until definitive care, which is your defibrillation, either by AED or the defibrillation monitor, is brought to the patient. All of these other fancy things that I'm going to be talking about now hasn't been shown to make a vast difference to patients. And if you take away anything from this talk, I think it is, what do I do in the first couple of minutes until definitive help comes along? So I'll recap that little statement right in the game. We're going to think into the patient's Two more seconds, and then okay. So eventually, rolls up a piece of paper and breathes for the patient. So that's what we want to move away from. So just as when do we start CPR? So when there are no signs of life. So we've moved away from checking for a pulse, because we're quite terrible at actually checking for a pulse. We're supposed to check for a pulse for 10 seconds, but we're not that great at picking up a pulse. And I think 40% of the time we think that there's a pulse when the patient says it's stopping. So look for signs of life rather than checking for a pulse. Check for agonal breathing. That's another sign of initiating CPR. And in your younger children, you can initiate CPR for choking as well. So that's in your children under the age of 2. When you withhold CPR, and that's exactly what Dr. Smith said. We should withhold CPR when it is dangerous for us to do so. So please, we've already got one patient. We don't want 2 patients. So please make sure that you're safe before you try any heroics on the patient. If the patient doesn't have if the patient has a do not resuscitate order, obviously it's not something that's in our law yet. It's something that we're working towards. But obviously, if the patient has said, "Listen, I don't want to be resuscitated," because it's not in our law, it is something that a lot of practitioners don't respect. And again, if somebody's got terminal cancer and they accidentally overdosed on their morphine, there's a lot of grey ethical areas in those instances. So I think that's the legal aspect that we've been quarreling with for quite a long time. And then we obviously don't start CPR if the patient's obviously dead. So if the patient's got the legal mortars, liver mortars, if there's mortal injuries, so if they're decapitated, if you're shot by completely exsanguinated. And please, if there's signs of life, I've seen a couple of times when people start CPR and somebody, once they start compressing, and they continue. So if there's signs of life, should definitely stop. In 2023, this is something fairly new, and we're going to go on the newer things now. The Advanced Life Support Society, the European Resus Society, came up with the termination of resuscitation guidelines. And there's 4 points which come up to about 99% predictive probability, positive predictive probability of a poor outcome in a patient. So either poor, like very poor neurological outcome, or not able to be discharged. And if there's no shock delivered prior to transport, so this is out of hospital cardiac arrest. So if you're a first responder and you come to the scene and there's no shock delivered prior to the patient being transported, so the patient's had a non-shock rhythm, or there wasn't a defib available generally within the first 10 minutes, that patient's got a very poor prognosis. If it's an unwitnessed cardiac arrest, that person also has a very poor prognosis. There's no bystander CPR, and this is very common in a drowning situation. This is one of the things that we can actually improve upon. Then the last point is, if there's no return of spontaneous circulation prior to the patient being transported, those patients generally have a very, very poor prognosis. So what makes a decision to initiate CPR difficult? So a lot of times we see patients with agonal bleeding, which is something that a lot of people think that, oh, the patient is bleeding, must have signs of life. So that's a primitive response. So please remember that agonal bleeding effectively means the patient's got very poor circulation. And it's primitive responses, that patient is effectively dead, and you need to CPR on those. But what makes it even more difficult is your post-ictal states and patients with seizures who can mimic your patient's agonal bleeding. So I think that's the difficulty that most of us, not most, like we have quite a bit. So is the patient post-ictal and I just need to put them in the recovery position, or is this actually agonal bleeding and they need to start CPR? So those are the difficult areas. Then there's fear of making the patient worse. It's a rational fear that all of us have, and obviously fear of being sued. In a Resus situation, there's very few times you're going to be sued. The patient's at their worst, you can't really make them any worse than they currently are. Always say the patient's dead, you can't make them any more dead than dead. So just something. So these 8 ill-call algorithms, we're going to be concentrating on 4 of them, and just little snippets from 4 that I thought I could concentrate on before we go into what the local applicability is. So with CPR for everyone, I think the biggest update was with respect to drowning. So previously it was, if you had patients that drown, bring them to shore, and once they're on shore, you can initiate CPR. But what they've shown is that if you just do ventilations, as you bring, so if preferably if there's 2 people, otherwise the ratio is going to drown. But if you are in a boat, you obviously can't perform CPR, chest compressions in a boat, because boats on the rock and putting yourself in danger. But if there are 2 people in a rescue and in a drowning situation, performing ventilation only resuscitation increases the favorable neurological outcomes from 7.4%, to up to 52%. So they've got a very good survival rate if you just start ventilations before you get onto land, where you can then perform CPR. So I think that's one of the big highlights that they brought up. Then that mirrors your up to discharge, so survival to discharge as well. So it's about 48% versus 6.9%. So it's a marked change if you just start ventilation, resuscitation fairly early, rather than waiting to get onto land before you start anything. Then the second part is, and I think it's globally, not just for drowning, but a lot of times we would try and get the defibrillator on or the pads on, and the move is away from putting the pads on first, but to getting in a patient who is like this, who's got no signs of life, to actually doing chest compressions first, starting to perfuse the heart, start perfusing the brain as well, before you deliver a shot in somebody who has a rhythm that's amenable to a shot. And then lastly, so I spoke about the ventilations in the drowning. When it comes to patient, with respect to basic life support, it's a very controversial topic, especially in resource limited setting. But I've brought it up here because South Africa is this very disparate world where we've got Bishop's Court and we've got Kanija. And the question is always how do we marry the two? And the data for drone delivery of AEDs is not that great. So it does bring an AED, which is the one thing that you can do. So other than bystander CPR, getting an AED to the right place at the right time is one of the things that does help quite tremendously for CPR. It does cost a lot of money. Maybe it's about 30,000 rand for an AED. And one of the problems that we've had with AEDs, especially in our clinics, in our response vehicles, is that they, one, get damaged, and two, they get stolen as well. I don't know why people steal AEDs. The second-hand market's not that great, but it does get stolen and does get damaged fairly easily. It's a Swedish study, so translating that data into South Africa is very difficult again. But when we come to the economics here of it, it's something that, as technology improves, it's something that we probably should be looking at to centralize where we're keeping all our things and seeing how we can get to it, how we can get it to the right place at the right time, instead of putting a whole lot in a whole lot of different locations with the risks that it inherently has. And then again, just emphasis on CPR before defibrillation, before you defibrillate the patient. I think the most interesting things come in with advanced cardiac life support. So let's start with extracorporeal resuscitation for cardiac arrest. Again, this you're going to find not a lot of paramedics, but it's a more commonly spoken about thing in the world of pre-hospital. Starting extracorporeal resuscitation for your cardiac arrest patients. The evidence the quality of evidence is of very low certainty. There is a trend towards benefit, but the number of patients in the majority of trials is very small. And with the inherent costs involved and the fact that there is no difference at 6 months, at the 6-month endpoint, this is almost a moot point for us in a South African setting. So I think that's one of the things that we should know about it, because people are going to start talking about it because it's obviously interesting, and we can do a lot with it. But I don't think it's something that we should be entertaining in a South African setting. The one thing that we should probably be thinking of is double sequential external defibrillation. So does anybody know what that is? No, it's basically using, so it's for shock refractory, it's for shock refractory ventricular fibrillation. So if you're defibrillating somebody with ventricular fibrillation or ventricular tachycardia that doesn't have a pulse, you've tried it 3 times, you've given them the adrenaline, and they're still in ventricular fibrillation. You've tried defibrillations 3 times. Trying it for the 4th time is probably not going to work. Trying it for the 5th time is also not going to work. So if you've tried defibrillation thrice and it's not working, the suggestion is that you need to change something. And one of the things that you can change is adding more electricity. So you're going from 360 joules to 700 and a lot joules. So you're going to 720 joules basically, because you're adding. So how do we normally defibrillate? So we're putting one pad here, another pad on this side. With double sequential, we're putting one pad in front and one pad in the back. And the harm that we might, so how much is defibrillated for? A lot of money, 60,000 rand for the defibrillator. Sorry, it's 150,000 rand. So it's a lot of money, and we don't obviously want to break it. So what we want to do is we want one person charging and then defibrillating 1 second apart to make sure that we don't damage our machines. So that's 1 second apart. So it's make sure that you defib, make sure that the patient's clear, defib, and 1 second later defib over the next machine. So that's about a fairly significant amount of energy that you're giving the patient. That is nice in a setting where you have 2 machines. I don't think we should be going and purchasing 2 machines for all our pre-hospital vehicles, because something like vector change, so in a space where you don't have 2 machines, all you can do is vector change. So you try it this way, just go front back. So that's one of the things that you can do to make sure that, and it has like a 20% difference in the recovery rates or termination of VF rates. Then earlier I said you can't make a patient more dead than dead, but apparently you can. So one of the teachings when I was started studying was that calcium is one of the things that you can give during a resus. So always give adrenaline, lots of time give sodium bicarb, and the other thing that we gave was calcium chloride. Remember, never calcium gluconate, because calcium gluconate needs to go to the liver and be metabolized. We give calcium chloride because it goes into the blood and becomes calcium and chloride, so 3 calcium. But if we giving calcium chloride without the proper indications, we actually worsen neurological outcomes and we actually increase mortality. So please remember, calcium is not a routine thing that we give during resuscitation. The 3 times that we should be giving calcium is if we've got a blood gas and it shows that the patient is hypocalcemic, and then if we've got a patient with renal failure and we think that they might be hyperkalemic, or if we've got proven hyperkalemia on a blood gas. And the last one is if you've got a patient with a calcium channel blocker overdose. That's probably the only 3 times in the resus that you should be giving calcium chloride. With newborn resuscitation, again, it was just more of the same. It was making sure that you maintain normothermia. And how do we maintain normothermia? We keep a cap on the patient, on the baby's head. Obviously, it's not the animal, but in a resus situation, especially in the preterm, because they're losing so much heat from the latent heat from the head. Make sure that the head is covered. If you need to cover the body, you can either use a plastic, a vacuum bag, or you can use clean wrap to make sure that you don't lose a lot of heat from the body. Then, in determining the heart rate, so a lot of times people will like, oh, I've got this fancy SATS probe. Please don't use SATS probes to determine a newborn's heart rate. It takes too long and it's supremely inaccurate in determining what the patient's heart rate is. Palpation is also less reliable than auscultation, and the gold standard is actually putting on leads to see what the patient's heart rate is. So if all in all, so the best way of determining the patient, a newborn's heart rate is putting on leads. It does take a little bit more time than auscultation, but it's much more, it is more reliable than auscultation. And then, so it's leads, auscultation, which is more reliable than feeling for a pulse, which is more reliable than SATS monitoring, which is the least reliable. And then remember that in newborn resuscitation, supplemental oxygen is not necessarily the initial phase. So only once you're starting chest compressions, then you're going to be needing supplemental oxygen. But the initial resuscitation of your newborn is done without any supplemental oxygen and just with the appropriate ratios. So why is this so important? So again, out of hospital cardiac arrest is a common thing, is a common event, and it's got about a 10% survival rate, even less for intact neurological status, and survival to discharge as well. So we're looking at about 5 to 7% survival rate. But there's a recent review in South Africa from 2020 which shows that it's actually doing terribly. So we've got about 1% to discharge in South Africa. And the factors involved there are obviously it's multifactorial, but how do we improve this? Where do we start? And there's a recent paper, it's not published yet, so it's attached to this document if anybody wants to read it. But it's how do we go about it? What's the most effective way of implementing interventions to improve out-of-hospital cardiac arrest? And we want to improve the chain of survival. And it's mainly, it's going to be on the left-hand side. Remember, so the interventions that they've ranked, number 2 should be community engagement. And these are, so number 1 is your termination of resus protocol. So don't start the resuscitation in those that don't need resuscitation. Number 2 should be your patients, your community involvement. And the Western Cape government was actually quite good at this in the EFAR, which is the emergency first aid and rescue program that they've implemented. I think they've trained up to 10,000 people so far. The problem there is that they're unable to maintain that skill. So people probably forget. So refresh that skill. How do we make sure that the data or the information that we've given people is maintained? And I think it's all our responsibilities to make sure that when people go for antenatal screening or not antenatal screening, antenatal classes, that this stuff gets incorporated into their things, because we want to make sure that the babies are resuscitated. We want to make sure that everybody knows the basics of CPR as well. So that's the things that's being taught in the EFAR training. Ensuring EMS vehicles are equipped with AED, so that we can take the defibrillations to the patient and do it as quickly as possible. Obviously, there's the limitations there with the vast population of the number of vehicles that we have. The CPR bystander training we spoke about, and then the targeted placement. So instead of looking at putting AEDs in every place, they're looking at putting it more with high-risk patients rather than and high risk areas like where people are getting attacks. So in children's at school events, so at sporting events, where they get sudden ventricular fibrillation and collapse, at mosques. Just if anybody is from a mosque committee, does anybody have an AAD in their mosque? And should we be having AAD in mosques? We have lots of old people in mosques that has a high chance of so it's just something that we need to think about. And so it's just identifying our high-risk areas and placing these AEDs in the high-risk areas to make sure that we have access to immediate care. Because remember, every minute that we delay defibrillation and CPR, it increases mortality by about 7%. Okay, so the quicker we can initiate CPR, the quicker we can defibrillate the patient, just improves the mortality significantly. It decreases the mortality significantly. Thank you.